Just making sure that we have our speaker. Are you seeing the welcome to ADAA slide right now?
I am not. So let's
You
see.
are not. Okay, let me just do one thing. Maybe end the recording for a second. Hi, everyone. Welcome to the webinar. My name is Dr. Deborah Kishnan. I'm the co-chair of the Public Education Committee for ADAA. That's the Anxiety Depression Association of America. And we are very excited today to be hosting the webinar, Hair Pulling, Skin Picking, and Nail Biting, Understanding and Treating Body-Focused Repetitive Behaviors. And our presenter is Dr. Susan Mouton Odom, and I'd like to tell you a little bit about ADA. We're the leading nonprofit organization in the field of anxiety and depression, and our goal is to improve diagnosis and promote the prevention, treatment, and find the cure for anxiety, depression, and stress-related disorders. I would like to invite you to check out our fabulous ADA website. You can find local CBT-based providers through our Find a Provider search engine. And also we have a great free peer-to-peer online support group. So I'd like to get started and introduce Dr. Susan Mouton Odom. She's a licensed psychologist in private practice and specializes in the evaluation and treatment of BFRBs. She's been treating these disorders in clinical practice for over 20 years and regularly presents at local, national, and international conferences. Dr. Mouton Odom has been a member of TLC for Body-Focused Repetitive Behaviors Scientific Advisory Board for 15 years and is the co-author of the book, A Parent Guide to Hair Pulling Disorder, Effective Parenting Strategies for Children with Trichotillomania. And I'm going to hand this over so we can hear all of the great information that, that we have available to us. So
Thank you so much, Deborah. Let's see if I can get to it. Okay. So I just wanted to, before we get started on what hair pulling and skin picking is, I want to talk a little bit about what it is not. And just to kind of go over some myths and misconceptions that are very common with these disorders. First being that hair pulling and skin picking are new phenomenon. What we know is they've been around for thousands of years. They even make reference in Homer's The Iliad and the Bible to hair pulling. Secondly is that people with BFRBs are very anxious or tense people. We have the common saying, I could just pull my hair out. What we know is that people pull their hair and pick their skin for a variety of reasons, which we'll talk about in a minute, not always anxiety. People with hair pulling and skin picking don't always have serious psychopathology or underlying psychiatric diagnoses. BFRBs are body-focused repetitive behaviors, which are hair pulling, skin picking, and other behaviors, are not self-mutilation. That is a common mistake that is incorrect. So oftentimes people think that people with BFRBs hate themselves or want to be disfigured or ugly. We know that this is not true. Believe me, people with BFRBs want to change their behavior. It is not a sign of a history of abuse. People with BFRBs are no more likely to have a history of abuse than someone without a BFRB. They're not simple habits that can easily be stopped. If that were the case, then people would simply stop them and it would be over. It's not the same thing as having OCD, and there are good treatments, and we're going to talk about that here in a minute. So as far as the prevalence, what we do know is that hair pulling affects between 1% and 5% of people, so it's relatively common, and skin picking affects just a little bit less, up to 4% of people. And there is some overlap between the two, but together it affects millions of people in the United States alone. The average onset is between 11 and 15 years, around age 12 for hair pulling and 15 for skin picking. And in children under the age of 12, it is about half and half boys to girls. Now in adults, it's almost 90% female for hair pulling and 80% female for skin picking. And we're not sure why that is. My guess is that more girls start pulling in adolescence around age puberty than boys. And that's why we see the incidence go up after the age of 12. Currently, both hair pulling and skin picking are classified as obsessive compulsive and related disorders in the Diagnostic and Statistical Manual. And then there's another classification that's other obsessive compulsive and related disorders, and that really just includes the other body-focused repetitive behaviors, which are nail biting, nail picking, cuticle picking, lip biting, lip picking, cheek biting, knuckle cracking, nose picking, and tooth grinding. And all of those kind of fall under this umbrella of what we're calling body-focused repetitive behaviors. We also know that there's likely a genetic factor, if not specific for hair pulling or skin picking, but for maybe BFRBs in general. And over the years, we've had different models of understanding them. Everything from it's a habit, to it's a disorder of grooming, to its psychoanalytic model, or there's some deep underlying sort of psychosexual stage that you're stuck in, and that's why you're doing it, to a learning model. But the one that we believe to be the most pertinent and to make the most sense is a comprehensive behavioral model, and that's what I'll be talking about today. But just real quick, I want to back up and talk about, because people think, oh, it's hair pulling, it's skin picking, what's the big deal? Well, there are some real physical and emotional and psychological consequences of BFRBs. The obvious ones for hair pulling being baldness or alopecia, and for skin picking being scars, wounds, and infections, which can be quite serious. But in addition to that, people get repetitive strain injuries in their arms and hands, calluses on their fingers. A trichobezoar is like a hairball. Hair is not digestible, so swallowing and ingesting hair can cause real digestive problems, which can result in having to have surgery. And oftentimes dental impact from pulling the hair between the teeth or nibbling off the root or the root bulb. And so really we see physiologically a lot of sort of negative outcomes of these behaviors, but almost more importantly are emotional. So people with BFRBs suffer shame and isolation. They generally don't talk about having these disorders or engaging in these behaviors, and so living a life of sort of hiding is fairly common. Oftentimes people will avoid relationships, avoid school or education, or career pursuits that they might have pursued if they didn't have a hair pulling or skin picking disorder. Oftentimes kids are teased or get negative reactions from others. There's also a fear of being detected and or teased or getting reaction from others. And we do see a higher incidence in adults of depression, generalized anxiety disorder, and an OCD in people with trichotillomania. And so there is quite an emotional impact. Financially, we see it's expensive. The cost of wigs, makeup, prosthetic eyebrows, and lashes are not cheap. Not to mention the time that people spend engaging in these behaviors. It causes to miss school or miss studying, so maybe you didn't make the grades that you would have made, missing work, missing time with your family, in relationships or sports. So it really does have quite an impact emotionally and financially. Missed education and career opportunities are something that we didn't know until the last 15 years, how big an impact that had on people with these disorders. So I wanted to talk a little bit about treatment. And for those of you who've never heard of a function-based approach or a functional analysis, it's basically we look at why a person engages in a behavior and how does the behavior function for them in their life. And the ABC model looks at antecedents, behaviors, and consequences. Antecedents being sort of what was happening before, the behavior being what you engaged in, the behavior you engaged in, the consequences is what happened afterwards. So we look at this to understand how these behaviors serve a function for a person. And in therapy, we spend a lot of time in the beginning really understanding this. So for example, an antecedent might be, it's later in the day, I come home from work, I'm really stressed from my day, I walk in the bathroom, the lights are bright, I'm looking in the mirror, and the tweezers are right there. So those are all antecedents. The behavior being, I pull out, say, my eyebrows or eyelashes. And then the consequence is I feel relief or gratification, I feel relaxed and calm and ready to go to bed. So it's looking at how this behavior is affecting me both before, during, and after. Now these triggers can be internal and external. So internal being how I'm feeling, what I'm sensing, what's going on inside of me, my thoughts, my emotions, versus external cues might be the bright lights, the mirror, the tweezers, I'm alone in the bathroom and the door is locked. And so as psychologists, we look at all of this when we're evaluating a person's experience and why they might pull or pick. So the comprehensive behavioral treatment is a function-based treatment. It was developed by Charlie Mansueto and his colleagues at the BTC in Greater Washington. And it evaluates each individual as unique. And so what I love about this approach, it's comprehensive and it's unique to each person. So we look at the same sort of modalities or domains within each person, but the treatment that we come up with is going to be different depending on that person's internal and external triggers. So treatment's very tailored and unique to each person. So typically in the beginning, we look at education, really understanding, teaching families or individuals about BFRBs, why they happen, how prevalent they are, and really trying to undo some of the shame associated with these behaviors. Instilling hope, treatment can be very effective. Helping them understand that this is functional, this is not just a bad behavior that they're doing because there's something wrong with them. It really is actually serving a purpose for them in their life. And then we also start talking about relapse prevention, because from the very beginning of treatment, we want people to understand that this is not a light switch that you flip and you stop and you're done, that this is a behavior that we have to learn to manage over time, and that there will be sort of 2 steps forward, 1 step back, but that we want to try and go in a positive direction. And so we call that relapse prevention, which is understanding that slips are going to happen, but it doesn't have to mean, oh my gosh, all hope is lost and we've gone back to square one. So in looking at the comprehensive behavioral treatment, I mentioned there are 5 modalities that we evaluate, and then the acronym we use is SCAMP, S-C-A-M-P. So sensory, cognitive, affective, motor, play. So I'm just going to kind of run through these because it affects how we do treatment. So some people are high sensory, and that means they rely on their senses for pulling or picking, or their senses really impact why they pull or pick. So it could be visual, searching for a certain hair, a darker, a lighter, a thicker, a coarser, or searching for a bump, a blemish, a clogged pore. They can be tactile, touching certain hairs, feeling the skin, taste. Oftentimes people will taste the hair, nibble the root, swallow the hair, and the same is true for skin picking. People will swallow bits of skin or scab or excoriate. Smelling is the same, smelling the hair or smelling the skin or scab or excoriate. Or hearing, and this is less common, but sometimes, especially with hair pulling on the eyelashes, we'll hear that people like the way that sounds as the eyelid slaps back on the eyeball. Cognitive refers to thoughts about hair pulling or skin picking. I have to pull out all of the gray hairs, they don't match, those coarser wiry hairs have to go, I can't stand to have a bump or a blemish or a pimple, I need to take care of it. So oftentimes the thoughts have to do with hair pulling or skin picking, but sometimes the thoughts are about something else. What happened at work today, or my child is really, their behavior is really bothering me, or I'm worried about something. Sometimes they're permission-giving thoughts. I'll just pull this one and then I'll stop, or I'm just going to pick this one blemish and then it'll be okay. And then it turns into more than that. And then I mentioned worry only because so many people with hair pulling and skin picking also have a diagnosis of generalized anxiety disorder, which is worry. And oftentimes we see people pulling or picking while they're engaged in worry itself. So the affective domain refers to feelings, and feelings can be before, during, or after a BFRB, and they can be positive or negative. You can pull because you're feeling anxious or tense, or bored, or sad, or angry, or worried, and pulling or picking can make you feel really good, excited, happy, relieved, but oftentimes pulling or picking is followed by feelings of guilt or anger or sadness. Sometimes a positive feeling, but oftentimes we see negative emotions follow, which can oftentimes lead to more pulling or more picking. So it's really important to understand feelings and how they relate to body-focused repetitive behaviors. The motor modality or domain refers to habitual movements or motor movements that oftentimes occur outside of one's awareness. So maybe it's how I'm laying on the couch with my hand up on my face, kind of fooling around with my hair, running my hair through my fingers, or touching my face and stroking the hair, or stroking my arms, searching for a bump or a blemish. So they're motor behaviors that oftentimes precede pulling or picking. And what this is important because oftentimes people with BFRBs are not aware that they're engaging in the behavior, at least at the start of it. And many times people will say, oh my gosh, I had pulled a whole clump of hair before I even realized I was doing it. It must have been going on for 15 or 20 minutes. So part of our job as therapists is to increase awareness, to really have them look at their behavior, monitor their behavior, dissect their behavior so that they can become more familiar and aware of not only when it's happening, but ideally before the behavior even begins. So we can ultimately prevent the behavior from happening. And then finally,
just to,
sure.
Sorry, just to chime in, I think that's a great point in that when people come to work on their BFRBs, they would say, I'm all too familiar with my behavior because I do it all the time and it's something that's always with me, but kind of changing the lens to actually observing the behavior and being curious about the behavior and more of a scientist observing a phenomenon versus being a victim of the behavior is a kind of a very different vantage point that can be healing in and of itself, to kind of take a step back and like, when am I doing it? And what fingers do I use? And how am I sitting? So it's surprising how much new information
That's an excellent point.
You can gain about a behavior that in some ways you're way too familiar with.
That's 100% true. And you're right. Most people who come to treatment say, oh, I know everything about my behavior, and they're shocked to learn over weeks. And really this process of gaining awareness does take weeks of really examining the behavior on a daily basis. And this is also part of undoing the shame. As you mentioned, I am not a victim of this. I can observe it as a scientist would observe it, and that helps me to have a little more sense of control over it. And that's a huge part of the work we do with people. And then finally, just to sort of talk about the last dimension or modality is place. So it's really important to understand, where am I when this behavior happens? What am I doing? Is it typically alone or with other people? Do I use implements such as tweezers or mirrors or bright lights? What time of day is it? And it oftentimes is the case that in different times of day or in different environments, it's a completely different experience. For example, in the bathroom by myself at night with the door locked may look very different than driving to work in the morning, in traffic with the music blaring. And so we would choose probably very different interventions for those two environments. And so it also helps people to start to understand and become aware of their behavior just by simply saying, where are you when it happens and what are you doing when it happens? So that's a really important domain. So once we've sort of gone through those 5 domains and understanding the entire function of the behavior, we start to select interventions. And as I said earlier, each person's going to get different interventions because each person is a little bit different. Each week they'll sample their interventions, 3, 4, or 5, and take notes about which ones are working, how many hairs did I pull, or how long did I pick, and then which ones were working, which ones are we going to kind of throw out, and then the next week we add new ones. So it's a process of adding new interventions and coming up with a complete treatment plan that's effective for that individual. So other things that are oftentimes added in the comprehensive behavioral model and are totally make sense to add depending on the unique individual are dialectical and behavioral therapy, or acceptance and commitment therapy, which both help with mood regulation and dealing with unpleasant emotions, anger management if a person is dealing with that, assertiveness if that is a need, for relaxation, to help with stress management or tension. Mindfulness practices can be very helpful, especially with awareness training and self-compassion, which I think everyone could use to kind of understand that these behaviors aren't a person's fault, and there aren't that they're doing something bad or negative. It's a part of how they're wired. So I wanted to, in just a few minutes we have left, is to talk about treating children with BFRBs, because it's such a different sort of an approach, even though we use the same model. When you look at the same domains, and oftentimes even the interventions are the same, we're working with the whole family. And so, although that, most kids start pulling around age 12, we see kids as young as 6 months of age pulling their hair. And we see young children also picking their skin, especially when it comes to mosquito bites. So the age of the child is very important when determining how involved parents will be. Parents are exclusively involved with a 3-year-old, whereas with a 13-year-old, the child is much more involved. And an 18-year-old, it's almost exclusively the child in therapy. Family intervention is almost always necessary to help educate the family, get them on board, and help them be helpful. Oftentimes, families will think they're being helpful and will actually do harm unwittingly. And so part of my job is to help them to understand how they can help their child. Oftentimes, more work is done with the parents than with the child. And to understand the concept of readiness. 100% of the time, parents will say, oh, yes, my child is ready. But what we'll find out in the first session is that the parents are very ready for their child to make change. And oftentimes, it's the child that is wanting to please their parents, but they're really still pretty engaged with the behavior and not so ready to quit. So part of it is offering incentives and helping the child to realize there are other things that they can use to get their needs met besides hair pulling or skin picking. And finally, I just wanted to cover some important resources. As Deborah mentioned at the beginning, the TLC Foundation for BodyFocused Repetitive Behaviors is www.bfrb.org. This is the most important resource in the world for these behaviors. It's free to join and is a wealth of information. ADAA obviously is a great resource with trained providers. There's a couple of books out there, one of which I wrote for parents with Ruth Gollum. And there's a couple of websites and iPhone apps that are very helpful for hair pulling and skin picking. So, that's the information I wanted to cover. And Deborah, I hope that was helpful for your listeners.
That was so helpful. I think the only challenge is that there's so much more information that we would love for you to share with us, and some information on the parenting and BFRBs and really getting into that cone model. So my hope is that maybe through ADA we could find a time for a part 2 of this webinar and go into even more detail, because you've shared tons of valuable information. So thank you so much, and thank you to whoever is listening in on this webinar. And feel free, if you do have any questions, you can email at webinars@ada.org, and you can feel free to email with questions or thoughts or ideas for webinars, additional webinars that you'd like to hear. We'd like to hear from you. And finally, consider making a contribution to ADA so we could continue to offer these kind of wonderful programs. So for now, have a wonderful day, and we will see you next time. Thanks again, Dr. Mooten Odom.
Thank you.